Okay, so good afternoon, everyone, and welcome to the UHC Invited Speaker Series. My name is Dr. Cheryl Barber, and I'm going to be serving as the moderator. And I am so excited about this talk because Dr. Sealy-Jefferson is one of my sheroes in the field of epidemiology, a colleague, a scholar, an activist who is just phenomenal. And I'm just really excited that you all will have the privilege of learning from her today. So I'm gonna read her short bio and then I'm just gonna let her jump right in. But Dr. Sealy-Jefferson is a social epidemiologist whose primary research seeks action to combat manifestations of structural racism that limit the human rights of Black families and communities. Dr. Sealy-Jefferson is the founder, director, and principal investigator of the Social Epidemiology to Eliminate Disparities, or SEED Lab. The mission of the SEED Lab is to conduct high-quality epidemiologic research to find solutions to the disproportionate burden of infant mortality among Black women. Specifically, Dr. Sealy-Jefferson's scholar activism draws from the reproductive justice framework and seeks to empirically document associations between systems of oppression and preterm birth, explicate the intervening biologic, social, and psychosocial mechanisms, as well as identify effect modifiers of these associations among Black women. The goal of her scholarship is to inform future intervention studies, policy change, and social activism. Dr. Sealy-Jefferson also has expertise in chronic disease epidemiology and is chair-elect of the epidemiology section of the American Public Health Association. Dr. Sealy-Jefferson completed her PhD in epidemiological studies from the University of Michigan School of Public Health, her MPH in public health practice from Wayne State University, and a BS degree in clinical laboratory science from Wayne State University. And I want to share this quote from her because, again, she's just a phenomenal inspiration to so many of us in the field. But she says this on her website. She says, "In public health, we have a moral imperative to fight for social justice. I find and help underdogs, and I say what needs to be said," and she truly does. "And I bring my whole self to everything that I do because I think that matters." And again, I think she's just been a powerful example of how to bridge rigorous scholarship with activism. As something that we need to, as epidemiologists, to hold close and know that the numbers are people and humans and folks that we need to be championing for. So anyways, without further ado, epidemiology of reproductive justice. Thank you so much for coming and sharing with us today.
Thank you so much. I'm gonna try to share my screen now. Okay, can you see the appropriate slide?
Yes, we're
yes,
seeing
you're good. Mm-hmm.
Okay, good. Thank you so much, Dr. Barber, for that introduction. And you were like this close to making me cry, girl. So thank you so much for that. And to Dr. Ana Diaz-Rue and Drexel University Urban Health Collaborative, thank you so much for this opportunity to share. And thank you all for being here. I look forward to our conversation. First of all, I want to acknowledge that I am occupying the traditional homelands that were stolen from the Miami people. Descendants of the Ohio Miami are members of the federally recognized Miami Tribe of Oklahoma and the unrecognized Miami Nation of Indiana. This statement is one small part of disrupting and dismantling colonial structures, as well as pervasive revisionist history. I also understand that gender identity is not binary, and my reference to women throughout this talk is in keeping with the original self-identification of the study participants in the data set that I use. I also want to acknowledge that the Loretta Ross came to my talk at Smith College last year. And afterwards, she came up to me and said, "Girl, your work is the epidemiology of reproductive justice." So that's what I call my work now. So in the time that we have today, I plan to discuss reproductive justice and several theoretical models that I use to guide my thinking on the problem that my work seeks solutions for, which is preterm birth, specifically racial inequities in preterm birth, whereas it's disproportionately burdening African American or Black women and people. I'll talk about some historical considerations that I think are important for understanding and doing something about these racial inequities in preterm birth, with a focus on neighborhood context. I'll then present to you some of the research that we've been doing over the last several years that links various neighborhood measures to preterm birth, and then there will be time for questions at the end. So first, let's talk about reproductive justice, which was coined in Chicago in June of 1994 by women of African descent for reproductive justice. So reproductive justice combines reproductive rights and social justice, and it's defined as the human right to maintain personal bodily autonomy, to have children, not have children, and parent Universal Declaration of Human Rights, which was a comprehensive body of law that details the rights of individuals as well as the responsibilities of government to protect those rights. And reproductive justice is not about choice, but about access, because if you don't have access, you don't have a choice. And it's focused on all reproductive rights, not just abortion. So that includes contraception, comprehensive sex education, sexually transmitted infection, prevention and care, alternative birth options, adequate prenatal and pregnancy care, domestic violence assistance, adequate wages to support our families, safe homes, and more. And reproductive justice draws attention to the history of white supremacy and how it operates in a capitalistic system to affect the present reproductive lives of individuals and communities. So now let's talk a little bit about fundamental cause theory, which was articulated by Lincoln Phelan in 1995 originally, and it was developed to understand why the association between socioeconomic status and mortality has persisted over time, despite the fact that we have intervened on a lot of the infectious diseases that were thought to mediate this association. This theory causes us to think about the cause of the causes or the risk of the risk. So it helps us to think about the root causes and not these proximal causes that are easy to measure and easy to intervene on. Fundamental causes have 4 essential features. The first is that they influence multiple disease outcomes. They affect these outcomes through multiple risk factors. They involve access to resources that can be used to avoid risks or minimize the consequences of disease. And the association between a fundamental cause and health is reproduced over time through the replacement of intervening mechanisms. An important implication of this theory is that health inequalities resulting from a fundamental cause cannot be eradicated by addressing intervening mechanisms because of the enduring inequalities in knowledge, money, power, prestige, and beneficial social connections that ensure that these mechanisms are replaced reliably. And the long-term impact of the fundamental cause can only be eliminated by reducing inequalities by Phelan and Link, and Link and Phelan, so they're switched the order of the authorship, but they were explicit about institutional and structural racism being a fundamental cause of health inequity. So now just to orient you to some terminology, systems of oppression refer to all of the isms. So sexism, racism, heterosexism, classism, ableism, all of them. And they involve systemic and directional power relationships among social groups in which one group benefits at the expense of other groups. These systems are multiple and interlocking, and their interaction is complex rather than simply additive. So whereas the system it operates among individuals who are embedded in institutions and permeates cultures, the 5 faces model describes for us qualitatively how systems of oppression operate. So there's 5 things. Exploitation refers to the systematic transfer of resources from one group to another. Marginalization is the prevention or limitation of full participation in society through exclusion from, for example, the job market or healthcare systems. Powerlessness is the deprivation of the ability to make decisions about one's living or working conditions. And cultural imperialism is the valuing and enforcement of the dominant group's culture, norms, and characteristics. And then violence, which is physical, sexual, and emotional violence, and the threat of violence, as well as policies and structures that condone violence. It's important to note that some of these manifestations of oppression could be understood in terms of more than one of these faces, and there's no hierarchy of oppression. These systems manifest in some ways that are similar, in some ways that are different from each other. Is important for this conversation because it illustrates how racial and gender oppression interact in the lives of Black women, and it helps us to understand how gender through race and class and how women are targeted for multiple simultaneous oppressions. And intersectional analysis considers the interconnections, not only as they influence individual identity and experience, but also as the systems themselves are entangled, co-constructed, and mutually dependent. The driving purpose behind an intersectional framework has always been to examine how best to shift systems of power, not just how best to understand or describe these systems. So we need to be focusing on transformation, on building coalitions among different groups, and working towards social justice. Because only when we can imagine the intersection of race and gender can we imagine the needs and perspectives of African American or Black women and people, rather than focusing on what's immediate and proximal. So now let's talk a little bit about preterm birth, which is the outcome that I spend a lot of my research focused on. It's defined as birth before 37 completed weeks of gestation. Most of the preterm births are spontaneous. Some of them are indicated, which means that the baby or the mother or the baby has some medical complication necessitating the early delivery of the baby. This is a multifactorial syndrome, and we don't know the entire etiology of preterm birth, but we know that it's the second leading cause of infant mortality, and this is an important gauge for overall population health. Preterm birth is also linked to adverse adult health outcomes, and there are stark, persistent, and disgusting disparities in preterm birth. Whereas it's the second leading cause of infant mortality overall, it's the leading cause of death among Black infants. Compared to other industrialized nations, the United States ranks poorly in terms of infant mortality. So this is showing you infant mortality per 1,000 live births from 1915 to 2017. I just want to make something as clear as possible. In 1916, Black mothers were 87% more likely to bury their babies before their first birthday than white women. In 2017, Black mothers were 122% more likely to bury their babies before their first birthday. 1916, 87%. 2017, 122%. In order to understand and make sense of these stark and persistent and disgusting inequities in preterm birth in this case, but in all racial inequities in which African American or Black people are more likely to be burdened, I argue that historical context is key. Here I'm showing you a timeline of the history of Blacks in this country, with 1619 marking the first record of an African who was enslaved in this country. From 1619 to 1964 is 345 years of inequitable treatment, poor health status, and absent or inferior medical care for African Americans. The Civil Rights Act of 1964 was 56 years ago now, and it was supposed to end segregation in public places and ban employment discrimination on the basis of race, color, religion, sex, or national origin. But we have evidence that this legislation did not, in fact, do what it was created to do. So the 56 years that we are now from the Civil Rights Act represents only 14% of the history of Blacks or African Americans in this country. Historical context, as well as unequal starting points, have health implications across generations, and the history of African Americans here is unlike that of any other racial or ethnic group, and this history matters for the current levels of the population levels of adverse health that we see. So this figure is adapted from Dr. Ana Diaz-Rue and colleagues, and it's just showing you a summary of the processes through which neighborhood physical and social environments could contribute to health and health inequality. So we have residential segregation and socioeconomic status, which is dynamically related to inequalities in resource distribution. These things impact both the physical and social characteristics of a residential environment. They also impact stress, which impacts behavioral factors, and vice versa. And all of these things, including personal characteristics, impact health and health inequality. So now let's talk about neighborhood context, which is important because neighborhoods group together beneficial or non-beneficial circumstances for people, like healthy foods and good medical care, recreational opportunities, etc. Neighborhoods were identified as an important determinant of health in the 1979 Surgeon General Report, which was a comprehensive approach to disease prevention. And then Williams and Collins in 2001 provided evidence that racial residential segregation is the fundamental cause of differences in health by racial group, because African Americans or Blacks live in starkly different neighborhoods than whites. These neighborhoods are often more disadvantaged in multiple ways, and where Black people live in this country is not random. And this association between residential segregation and poor health and mortality is not about individual level resources. So it's independent of individual level socioeconomic status. So the way that we measure neighborhood effects is usually investigators use address data and link it to data from like administrative data sources like the US Census, and we call this type of neighborhood measure objective neighborhood measure. What we can get from the US Census data is sociodemographic characteristics like neighborhood poverty or unemployment, one of these or a couple of these single items, or we can create an index of disadvantage by combining multiple of these individual items into a summary score. There are some advantages to using objective neighborhood measures because they might capture important structural aspects of a residential environment that residents cannot or not perceive. For example, neighborhood disadvantage might shape access to local resources that consequently affect health, even if people have a generally positive appraisal of their residential environment. An issue though is that across the literature, there's great variability in terms of what investigators use, in terms of which of these sociodemographic characteristics people are using to proxy neighborhood effects. So I might be interested in the percentage of minoritized groups in a residential environment, and another investigator might be interested in the median income. So across the literature, we don't have conclusive evidence about whether and how neighborhoods matter for health, because a lot of people are using different variables to proxy neighborhood effects. Another issue is that the only data that we can get from census data is sociodemographic characteristics, which might not equal the true neighborhood construct that we're interested in. So if it's just sociodemographic characteristics, that tells us nothing about tax foreclosures or mass incarceration or evictions or other things that we know matter for health that are not health promoting, but we can't reliably proxy those things just using socioeconomic characteristics. We can directly measure residential environment features by having trained observers go out and assess the housing stock, for instance, or we can directly query study participants about their perceptions of the residential environment that they live in. And so we call this survey data, where we directly query study participants, we call that subjective neighborhood measures. And I'm going to show you some data from our prior work that uses both of these types of neighborhood measures. And the data that I'm going to be showing you comes from a cohort study, the Life Course Influences on Fetal Environment study. The original intent of this study was to decide whether and how racism is related to preterm birth in African American women. We have 1,410 study participants, which represents 71% of the people who were approached for participation. This is a retrospective cohort. Data were collected between 2009 and 2011. And we have surveys, medical records, as well as current and prior addresses for the study participants. And they were eligible to participate in the study if they delivered a singleton birth at a suburban hospital. And they were recruited in the immediate postpartum period, which means after they delivered their babies, but before they were discharged from the hospital, they completed all of the study materials. So this is just showing you geographically where our study participants live. So they were largely in Wayne, Oakland, and Macomb counties in Michigan. And this other, this colored figure is showing you, I geocoded the address, you can see about where across these three counties the study participants live. So in this first study, we were interested in women's perceptions of the physical and social residential environments, and preterm delivery. And so we examined whether perceptions of neighborhood walkability, food availability, safety, social cohesion, and social disorder were associated with risk of preterm birth, and we thought that educational attainment might modify this association. So what we found in this first study is that, interestingly, the traditional risk factors that we know predict preterm birth did not predict preterm birth in this cohort. This is a all African-American cohort of various socioeconomic characteristics, and the preterm birth rate was 16.4% of the sample had a preterm birth, which is a lot higher than the national average. And it was surprising that these traditional risk factors did not predict preterm birth. We found also no evidence of an association between any of our 5 subjective neighborhood measures and preterm birth in the overall sample, but we had evidence that the relationship was different depending on educational attainment. So in models, we stratified by education, and we found that among the women with lower levels of education, 4 of the 5 perceived neighborhood variables were associated with preterm birth, and they were in the expected direction. And we saw no significant evidence of an association between any of the 5 perceived neighborhood variables in preterm birth in the group with higher education. So then we were interested in, okay, so of these 4 significant associations that we found between perceptions of neighborhood context and preterm birth, how do they operate? So we were interested in psychosocial factors, including perceived stress, psychological distress, and depressive symptomology as potential mediating factors for these associations. And basically what we found were 2 things: that the relationship between Black women's perceptions of their neighborhood safety was associated with depressive symptoms, and that was associated with preterm birth, so there was an indirect effect through depressive symptoms, and that there was a direct effect of neighborhood perceptions of neighborhood disorder and preterm birth, net of the impact through any of the psychosocial factors that we examined. So then we wanted to switch gears and to assess whether or not objective neighborhood disadvantage was associated with preterm birth, and whether religious coping was a significant effect modifier, because we know that Black women use religious coping to deal with chronic stressors like neighborhood poverty, and we know that religiosity has been conceptualized as a social determinant of health. We hypothesized that the association between neighborhood socio-demographic disadvantage and preterm birth might be modified by religious coping. So we have 3 domains of religiosity or religious coping. The first is organizational religiosity, which measure the frequency of religious service attendance. We have non-organizational religiosity, which was measured with 2 questions. One was the frequency of praying for yourself and the frequency with which you ask other people to pray for you. And then we have subjective religiosity, which was the satisfaction that our study participants had with the relationships with people in their church or place of worship. So the main findings here were that, again, no evidence of a main effect between our neighborhood disadvantage index and risk of preterm birth. However, this relationship seemed to vary by non-organizational religious coping, specifically asking other people for prayer. So we found that women who lived in highly disadvantaged neighborhoods and who infrequently asked other people for prayer had nearly 30% higher risk of preterm birth. So then we know that life course stressors matter for health. And so we were interested in early life neighborhood context and whether or not that works with current perceptions of stress to impact preterm birth in Black women. So we had some data, some survey data on the neighborhoods that our study participants lived in when they were 10 years old. So they reported to us their perceptions of the neighborhood social disorder and social control, and we thought that those would have opposite modifying associations on this relationship. And so this is sort of the conceptual model for what we were looking at. Women's current perceptions of stress and whether that's related to preterm birth, and whether or not early life neighborhood social disorder magnified this association, and whether early life neighborhood social control buffered against this association. And so what we found, again, no strong evidence of a relationship between perceived stress and preterm birth in the overall sample, but we did have evidence that this relationship differed by early life social disorder, which is in line with our prior work on have current perceptions of disorder in the neighborhood that women lived in having a direct effect on preterm birth. So this also supported a similar hypothesis. And we found that women who reported high perceptions of stress in the past 30 days, plus who lived in neighborhoods that they defined as highly disordered, had a 31% higher risk of preterm birth. We saw no association or little evidence of an association for the low early life social disorder group. So then I was like, all right, so that's all of the survey data. That's all of the census data that I can get to measure sociodemographic characteristics. What else might matter? And so I sort of thought about what it was like for me living in the similar neighborhoods to our study participants, being from Detroit, and like thinking about what I thought might be going on. So I was able to find some data on neighborhood tax foreclosures. And so in this study, I linked these neighborhood tax foreclosures to the life study, and we were able to assess whether or not that plus educational attainment was associated with preterm birth. And we know contextually that the foreclosure crisis has altered the social fabric of many neighborhoods in the United States in ways that might be connected to stress and risk of preterm birth. And research suggests that living in neighborhoods with high foreclosure is associated with other poor physical health and mental health outcomes, but none had looked at this relationship and preterm birth among African Americans. So we have, again, we linked survey and medical record data to archival block group level tax foreclosure data. And we got this data from the county treasurer. And we have, for this study, we had absolute neighborhood tax foreclosures because we lacked an appropriate denominator to calculate true rates of neighborhood level tax foreclosures. And so what we found is that there were weak correlations between neighborhood tax foreclosures and other subjective and objective measures that we had previously looked at, which tells us that this neighborhood tax foreclosure measure might be quantifying something that's importantly different from women's perceptions and sociodemographic characteristics of a residential environment. There was no strong evidence, again, of a main effect in the overall sample, but higher educational attainment appeared to be protective. Tax foreclosures capture extended disinvestment and neighborhood decline, and this may cause spillover effects on health for residents. So here we wanted to highlight that we should be focusing, especially among these groups that are disproportionately burdened by things, on community assets as well as resilience as a reframe to this narrative that preterm birth has existed for so long and it's intractable and we can't do anything about it. Actually, we can. We need to be focusing on what people who are in the high-risk group are doing to avoid these adverse birth outcomes. So then I was like, okay, what else? What else do I think matter? And I was able to get my hands on some neighborhood level mass incarceration data and link that to the live data set. We know that the United States is exceptional in incarcerating its own residents. It has the largest proportion of residents in jail or prison globally. From 1978 to 2009, the number of people in federal and state prisons increased 430%. 50% of African American women have an imprisoned relative compared to 12% of their white counterparts. And many urban areas are deemed million-dollar blocks because because at least $1 million taxpayer dollars are spent every year incarcerating residents of a single city block. Mass incarceration is a dominant social determinant of health because it punishes accused offenders and is a fundamental cause of persistent inequality. So we were looking at, okay, this data on mass incarceration was only available for the year 2008. The life study participants were enrolled between 2009 and 2011, but they also reported prior addresses. So what I did is I figured out where they lived in 2008, and I linked all of the people for whom I had their zip code in 2008 to data from this Justice Atlas of Sentencing and Corrections, and I was able to measure preconception zip code mass incarceration and whether or not that is associated with future risk of preterm birth, because this prior time point was up to 2 years before the study participants enrolled in the study. And We have zip code level data on 8 mass incarceration variables, and they're expressed in rates per 1,000 adults. And we thought that marital status as well as maternal age at birth might modify this association. So it was concerning that we found that the average prison admission costs for the zip codes that our study participants lived in were 10-fold higher than the average in the state, and they were definitely higher than what we would expect to see in the United States. And we found little evidence of an association between any of the 8 mass incarceration variables and preterm birth in the overall sample, but we did find evidence that this relationship might vary by maternal age at birth and marital or cohabiting status. So we saw that younger women who lived in neighborhoods with high prison admission costs had higher risk of preterm birth, and married women who lived in neighborhoods with high prison admissions due to new court cases had lower risk of preterm birth. I want to highlight that every $1 increase in state correction spending is associated with a $1.40 decrease in social program spending. And given that younger mothers are more likely to utilize these social services, underfunding impacts the range and availability of these services in these communities, and older women might also have more social capital to buffer against the influences of living in such residential environments. So now I want to talk about some work that hopefully is soon coming. You'll be able to read it when it comes out, hopefully in the next couple of weeks, on housing instability caused by evictions. Residential evictions are the most harmful source of housing instability. 2.3 million low-income renters per year are evicted. Evictions are an important determinant of health. Many people pay more than 50% of their income in rent. 1 in 4 renting families pays more than 70% of their income in rent, which is atrocious. And only 25% of families who qualify for affordable housing assistance actually get it. Poor women of color have the highest risk of evictions. And Matthew Desmond, who pioneered the study of evictions in society, says that eviction is to Black women what mass incarceration is to Black men. It's a cause and it's a consequence of poverty. Black men are locked up and Black women are locked out of their housing. So this figure is showing you a comparison of eviction rates over time, and I'm showing you data from Michigan, but there's data from all of the states actually. And this is showing you that across time from 2000 to 2016, eviction rates in Michigan were higher than the rates overall in the country. And as you all know, this problem is going to be exacerbated with this current pandemic. And it's unacceptable because housing is a human right. So what we did is we linked neighborhood level eviction data to the life data set. And we were interested in whether this predicted preterm birth and whether marital or cohabiting status was a significant modifier, because unmarried mothers have increased risk of adverse birth outcomes, including preterm birth, and marriage might increase access to health services, financial security, and social support. So again, I linked data from the Eviction Lab, which has eviction data from 2000 to 2016 at the Black group level for most cities in the country. So our main findings were that eviction filing and judgment rates were, again, just like what we saw in prior analysis, were not strongly correlated with the other neighborhood variables that we had that we had examined previously. It was also striking that the range of evictions in the neighborhoods that our live study participants lived in went from 0 to 78 eviction judgments per 100 renter occupied homes. And the eviction filings ranged from 0 to 132 eviction filings per 100 renter occupied homes. So this means that some of these homes had more than one eviction filed against them in a 12-month period. We found that there was no evidence of an association between neighborhood eviction filings and judgment in the overall sample, but the results seem to vary by marital or cohabiting status. So Black women who were married to or living with the father of their baby and living in neighborhoods with high eviction filings had a 25% higher preterm birth rate, and married or cohabiting women who lived in neighborhoods with high eviction judgment rates had 18% higher preterm birth. So we conclude then with that all of the evidence that I've just shown you sort of supports this idea that social factors don't operate in isolation. Neighborhoods are policy relevant and they are modifiable and they are a necessary component of a reproductive justice agenda. Within group analysis are important and necessary to help us to understand risk factors as well as protective and resilience factors, as well as mediating pathways so that we can intervene on some of these associations. And we need data and we also need action. So we shouldn't have to quantify all of the ways that adverse neighborhoods matter for the health of Black communities in order to do something about it. We know certain things aren't health promoting, so we should just intervene on those. So with that, I would like to acknowledge with gratitude the life study participants who trusted us with their data for the sake of finding solutions to racial disparities in preterm birth. I would also be remiss if I didn't acknowledge my co-authors in the work that I presented today, as well as my Social Epidemiology to Eliminate Disparities lab, as well as our funders. So this work was funded by National Institutes of Health grants, as well as some new funding that we just got, and this project just started in September, focused on court-ordered evictions, as well as illegal informal evictions on the health of Black families in Detroit. And with that, I thank you so much for your attention. I will stop my share, and I'm so excited for our conversation. Thank you so much for your presence.
Thank you so much, Dr. Sealy-Jefferson and Shawnita, for that amazing breadth of evidence that you have produced over the last few years in your career. We're going to now open it up for questions, and if you would just drop your questions in the Q&A function, I will relay those questions to Dr. Sealy-Jefferson, and we'll have a conversation about what has been presented. But again, thank you so much for that. I'm also seeing a lot of thank yous in the chat as well.
Thank you.
All right, so the question is from Dr. Irene Hedden. She's excellent talk. I'd love to hear more about how you're capturing informal evictions in Detroit.
Yeah, you know, so this project is going to be, we don't have any data on informal evictions. Okay, so we're going to have to, so this project is going to be community-based. I have assembled a team of 13 Black women from various community-based organizations to help me co-create, lead, and implement this research project. So we're going to do some surveys. We're going to do some in-depth interviews with Black women who themselves have experienced informal or illegal evictions in Detroit and the surrounding suburbs, because I don't think this is specific to Detroit. This is a Black women and people problem. So we're gonna have this community advisory board to help us to think about what makes most sense in terms of quantifying this. But again, there's no model. Okay, so this study is gonna be novel in a lot of ways, but we're going to uncover what is in plain sight. I mean, I feel like it's not even an uncovering, because we know that 40 to 50% of all evictions don't go through the court at all. Okay, so these landlords are changing locks, they're putting people out. There's a lot of things that are happening, and we're not gonna take it. Okay, so we're gonna quantify, we're gonna use both empirical and qualitative, so quantitative and qualitative methodologies, so that we can highlight, shine some light on, point to these crimes against humanity that are happening, that have been happening, but it's not quantified yet, and we're going to quantify it because there's a saying, no data, no problem. Mm-hmm. We know there's a problem, so we're going to quantify it, and we're going to pair that with social activism. We're going to pair that with wide dissemination strategies, which will be, you know, not limited to peer-reviewed scholarship, but also some thought pieces, some amplifying of people's stories. And we are going to be pushing for, and we're not taking no for an answer, we're going to be pushing for policy changes. We're going to be pushing for consequences for landlords who violate people's rights and who discriminate against Black women and families. and we're gonna produce the evidence. We're gonna produce the evidence, and we're going to be engaging in all kinds of counter. You know, we're not taking it. So that's what I'll say. I'll just say that we're not going to take it.
That's amazing. I really like the way that you're talking about documenting, you know, what's hard to document by using the voices and lived experiences of those in the community. I think that's a really powerful model for how we get at this data that is quote unquote hard to capture. So that's really powerful. Another question is, I was wondering if you know of any evaluated policies or interventions that have been developed to specifically support the needs of Black pregnant women, women and people that have shown promising results for reducing preterm birth and infant mortality.
You know, sometimes I hesitate to say what I'm about to say, but I'm going to say it anyway.
Of course you are, and that's beautiful. Go ahead.
It's true. So that figure that I showed you from what showed infant mortality rates from 1915 to 2017. As a population level health researcher, that data tells me nothing has worked. Mm-hmm. Okay. So, and the inequities have gotten worse, which means we haven't gotten to the root cause, which is racism, structural, mm-hmm. institutional, systemic racism. We haven't addressed that. So all of these interventions that have been focused on various things at the population level haven't reduced the inequity. Mm-hmm, mm-hmm. So to me, my mind is like, nothing has worked. I mean, mm-hmm. there are pockets. Some things have worked for individual people in smaller scale improvements, but to me, that's not enough. That's not gonna work because Black women are burying their babies in 2017 were 122% more likely to bury their babies before their first birthday than white women. Make it make sense, because in 1916, it was 87%. If you just look at the timeline, 1916 was a very specific point in our history. Mm-hmm. So you mean to tell me in 2017, the rates of infant mortality in Black communities are higher than they were back then? And that's an underestimate, of course, because data weren't collected for everybody at the same rate. But it appears to me that nothing has worked. That's a level of truth that we have to take. Mm-hmm. So I can't in good conscience point to anything that at the population level has worked because the data don't support that.
Right.
So now what it's gonna have to take is those of us who are disproportionate, those of us who are members of communities that are disproportionately impacted by everything, we die more from everything, we get more of everything, we die more, we live shorter, sicker lives. We're going to have to take up the charge of leading the conversation because nothing has worked. Mm-hmm. What do we think is going on? Mm-hmm. What do we think is necessary in order to make changes? Mm-hmm. We have to be the ones leading the conversation. We have to center ourselves, center our communities in these solutions. Mm-hmm. Center the voices of the people who are most likely impacted, who are the most disproportionately impacted, and then go from there, like find the solutions from there, because everything that has been done hasn't worked.
Absolutely. Thank you so much. So one thing to follow up on that, you talked about using community stakeholders and Black women in particular in your study. I'm really excited to see how you've done that. Can you talk a little bit about how you've engaged those women, who they are, and what you found even in the short period of time, with the study starting in September?
Mm-hmm. Yeah, that's such a good question. So what we've done is we've identified community-based organizations and relevant stakeholders across multiple sectors. So we have, this project is focused on housing justice. We have Salvation Army, we have COTS, we have various housing justice organizations. We have certified nurse midwives, we have registered nurses. So a lot of it is like me thinking about like, okay, I'm from Detroit and I know people. Okay, so like who do I want? So this was a very humbling opportunity for me to create a team from scratch, to pick the people that I work with across the board. So I was very intentional with this budget of this grant. So it's almost $1 million grant over a course of 3 years. And the foundation allowed me to do it my way, which is amazing. So 71% of the budget for this $1 million grant is going to the education of my students, to fund 2 Black women consultants, to fund this community advisory board, and to our study participants who are, everybody's getting compensated for their time and intellectual contributions to this work. So one of the things that I've done is I've just reached out like to a lot of people, and I've had 30-minute exploratory conversations about the project, about me, to see if they want to engage, if they want to commit to. So this community advisory board will serve 40 hours a year for 3 years. We're gonna have our kickoff meeting in about a week now, not this Saturday, but the following Saturday. And they're gonna help me with everything. So what I wanted to do, so again, 71% of the budget is going from my institution to the community. I don't have any co-investigators on this project who are colleagues. It's me, my students, and this community advisory board, because I just feel like we have to do it different.
Mm-hmm.
I'll just be honest, I'm doing something that I haven't seen before.
Mm-hmm. Mm-hmm.
Because it just feels like the right thing to do. This team is going to be for us. This project is for us, by us, unapologetically, because the data tells me a very specific thing, that everything that has been done hasn't worked. So if I haven't seen this before, maybe this will work.
Mm-hmm. Mm-hmm. Mm-hmm.
So it's 13. So I reached out, I sent emails to probably 30 something people, 37, like almost 40 people. And I'm trying to be specific about having a range of people's expertise, because there's different ways of knowing. So what I didn't want is researchers on this community advisory board. I wanted actual people who had been displaced by formal and informal evictions. I wanted people whose families also had been put out. I wanted people who don't work in academia at all, because their voices, I wanted to create some space at the table for people who, I'm just gonna say, I know for a fact, my colleagues and people that I work with wouldn't create space at the tables for these kinds of people. Mm-hmm. So to me, if they don't matter, I don't matter. Mm-hmm. So again, I'm just creating some space. And actually, this community advisory board is going to be something special for me and my team, because this work is going to be disgusting. Mm-hmm. So I'm gonna need some safe space and some community and some ways to recharge and feel supported. And unfortunately, I don't get a lot of that in these ivory towers. So this is gonna be a full mission. This community advisory board is gonna help me do the work, but they can also, it's about community, it's about capacity building. It's about me also providing opportunities for capacity building to this community advisory board, because I want them to be able to compete for funding outside of their connection to this university that I'm associated with. And work that matters in their community. So to the extent that we can do some study design training, some epidemiologic methods, some grantsmanship, any kind of personal development things, that's also going to be part of the work, because I feel strongly about giving them resources in terms of how they can be competitive for future funding with me and without me.
Yeah, no, that is,
I'm
loving it. I'm so loving this. And I mean, it speaks to, one, recognizing the power that is latent in our communities, even though we've been impacted and harmed by these structures and these systems of oppression that you talked about early on. There's so much power and knowledge and expertise. And I am just really appreciative of this kind of model of engagement that really is a partnership, and it seems like an equitable partnership, and that's really, really powerful. Have you had any comments from have people said how excited they are that you've approached, and can you tell us about some of how they've responded to you even coming to them?
They have, and so so I'll also say that everybody's getting paid US dollars. I'm not paying the advisory board with flattery, with compliments.
Yeah.
Or a gift card to a store that they're never going to go into. They're getting dollars, green cash money. So that's also part of it. Is like, I only asked for a 30-minute conversation with these people, because from here on out, any time that they invest in this project, they will be paid. So that's something that they're like, oh my goodness, like what? So a lot of them are just like, thank you so much for doing this work. Thank you for not being one of these bougie academics. Thank you for being real. They have really like blessed me with their work. Thank you for not a lot of people come back. Here, $1 million grant, and I'm funneling the money into my community. People, and it's important because they have brilliant ideas. There's so much brilliance in places like Detroit, and don't even engage, or when people do engage, it's exploitation. It's the intellectual property from these communities, and then leaving the community no better than it was before they got there. That's colonialism. And again, I'm just trying to do a difference. So I have a range of people on this cab, and again, we haven't, we're gonna have our kickoff meeting soon. But in the 30-minute conversations, a lot of the times I would be emotional because how affirming these women have been to me and encouraging me to do the work and saying, thank you so much. I'm excited. I want to be part of the solution. I'm already doing it. I'm working in the shelter. I'm working with teenage parents. They already doing the work. They just want to feel like they are a part of the solution. And I feel honored that I can have the opportunity.
Yeah, no, that's really powerful. I'm literally almost in tears, but I need to get through some of these other questions because, again, I like that your approach to research is one, a proper diagnosis of these problems, but a solutions that incorporate those most directly impacted. And I think we need to be doing more of that, especially given the data that you show that nothing has worked. So how can we do this differently and do this work differently? So again, I think it's really powerful. Let's see. So there's a question from Stacy Kalem. For those of us who work in MCH public health practice, what do you see as some of the needed interventions, policies based on your work? And so you said that, really nothing has happened. You're still learning, I think, from this project, but what are some interventions or policies that you think could work in this space?
So I think, the eviction data is in development, but there's clear evidence of social programs that will fund. Only 25% of people who qualify for housing actually get it. There's legislation that has been defunded that limits the amount of social support, social services that deserving and communities need, but they aren't getting it. So that's an example of it. I think so. What we looked at mass incarceration. Okay, policies around that would help everything. Okay, we talked about women's perception. So like the tax foreclosures. So what we saw in that paper was that the state of Michigan was violating its own constitution by illegally inflating the assessments of people's property home values, and so property taxes were illegally inflated. So then the state and the city foreclosed on the home, sold it at auction, left it dilapidated. So there's a lot of systems that are in place that have roots in redlining, that have roots in white supremacist ideology that have to be targeted. So the way that racism works is it's everywhere. Racism is everything. It impacts every person who is minoritized in this country every day, every way. So what we're going to need is the majority population who will start paying attention to all of the ways that racism has structured our society, every single way, and do something about that. Because actually, it's not enough Black people to undo racism. Even if we wanted to. We're 30% or less of the population. This is going to be people who benefit from racism, which is every person who is not a person of color, Black, Indigenous, or a person of color, to take up the responsibility of figuring out which ways that racism is showing up in our society that I can do something about.
Absolutely.
We need a political will. And we need enough of people who benefit from racism, which is every single white person, to decide how am I going to help? Because saying Black Lives Matter and saying, I think racism is a public health strategy, that's not sufficient. We need action. We need some hard conversations. We need policy changes. We need specific investments. We need truth, reconciliation, and reparations. That's a good policy that'll decrease the disparities and inequities in maternal mortality and morbidity, as well as infant mortality and morbidity.
Right. So we got root cause problems, we need root cause solutions is what you're saying. And I think it's a good place to end this webinar. I mean, again, thank you for speaking truth. Thank you for speaking so powerfully. Thank you for the model you are to me as a colleague, but to so many of us. Really powerful work, sending light and so much just strength as you go through this study. As you know, it'll be difficult, but it's also going to be really powerful. So just thank you so much for your work. If there are other questions, feel free to, if you want to stay on, Dr. Sealy-Jefferson is also going to be joining through a Zoom link that's now in the chat. At 1:15, if you want to do a more intimate setting with Dr. Sealy-Jefferson, ask her some more questions. Students on the call, I would encourage you to talk to her. She's an awesome, phenomenal mentor. So she'll drop, so I'm sure she'll have some words of wisdom for students who want to attend, but please follow up today. Again, it's right after this at 1:15. The Zoom link is in the chat box. But again, I just want to say thank you so much. So many things are coming through the chat to just say that, this was a phenomenal presentation and we are really honored to have had you here today. So thank you, Dr.